So good afternoon. We'll go ahead and start with the first session in the afternoon. Thank you very much all for coming. And again, I would like to thank the supporters, and please in the break, try to take your time and visit their exhibits. Thank you very much. We'll go ahead and turn the session to the moderators. Go ahead, please.
Well, thank you for all of you who decided to stick around after lunch. I'd really happy to introduce Dr. Bradley McGregor, who comes to us from Boston. He's currently the clinical director of the Lang Center of GU Oncology at the Dana-Farber, and he's going to give us an update on GU malignancies.
Thank you so much for the opportunity to be here with you here today. And so we only have 15 minutes to talk about updates in GU malignancies over the past year. And I think I could do an hour on just what happened the past week. So we're going to go through this pretty quickly and try to give you an update on where things stand for GU malignancies. Here's my disclosures. So we're going to start with renal cell carcinoma. And this is a busy slide, but it just shows you where we are in terms of the frontline management of renal cell carcinoma. So we've seen multiple updates for the trial. So we now have clear data that combination therapy improves overall survival in the frontline therapy for renal cell carcinoma, whether that be IO-IO with nivo-ipi or an IO-TKI. And we have 3 IO-TKIs that improve overall survival, and then we have nivo-ipi, which improved overall survival. And I think what I want to point out here is seeing long-term follow-up for both the Checkmate 214, which is nivo-ipi, and Keynote 426, which is pembro-axi. And at ESMO, they presented the data for 214 with a median follow-up near 70 months. We can see that the overall survival and intention to treat was 56 months versus right under 40 months. Really, really remarkable. They did conditional survival data. So if you respond to nivo-ipi and you have response at 2 years, your chance to maintain that response at 2 years later is upwards of 90%. So really quite remarkable. We haven't seen that tail of the curve with TKI-IO. And at ASCO, they presented data for Keynote 426, looking at pembro-axi. And while yes, it certainly improves survival in the frontline setting, very remarkable data, with extended follow-up, the median survival is only 46 months versus 40 months. So obviously can't compare trial to trial, but there really does seem to be a tail to the curve with IO-IO. And that's when I'm thinking about that frontline management of renal cell. I think about it, but I'm hoping that I don't have to get my patients to this point and that we can do something before they reach metastatic. And that brings us to the state of adjuvant therapy. So adjuvant therapy, we try once, we try again with the same drug. So there's been multiple trials with TKIs in the adjuvant space. Assure trial looked at sunitinib, sorafenib, completely negative. The PROTECT trial with pazopanib, completely negative. This is looking at DFS as that endpoint. So, well, maybe axitinib, completely negative. And then sunitinib, because, well, if it didn't work once, we'll try it again. They did another trial, really high-risk patients, and there was actually a disease-free survival benefit by just about a year, but actually no overall survival benefit with extended follow-up. And 30% of patients had discontinued treatment due to toxicities. So given what we just saw, that IO seems to really have efficacy in the management of renal cell carcinoma, there are several trials that are ongoing evaluating the role of immune checkpoint blockade in the perioperative space. And this is the first that was presented. So this is Keynote 564, presented at ASCO, took patients with high-risk renal cell carcinoma, post resection, and they were randomized to pembrolizumab, 200 milligrams every 3 weeks for a year, or placebo, with a primary endpoint of DFS per investigator. And I do want to highlight who is eligible for this trial, because this is not going to be all your patients with renal cell carcinoma. So this is going to be really high-risk patients. So the intermediate high risk was PT2, but they had to be grade 4 sarcomatoid features. So your PT2, grade 3, grade 2 would not have been eligible, or they could have T3 any grade, T4, N1, and then the M1 NED. So these are patients who have disease that's resected, now that no disease, but that had to be within a year of the nephrectomy. So we know if you have an isolated lung met 3 years after nephrectomy, you can do really well without any additional therapy beyond surgery. So this had to be NED after resection within 1 year of nephrectomy. Here's the baseline characteristics. The one thing I want to point out here is a minority of the patients were M1 NED. So 6% of patients were M1 NED. And here's the key slide. This is DFS by investigator intention to treat population. You can see a hazard ratio of 0.68 with a highly statistically significant p-value. This translates into an improvement in DFS at 2 years of 77 versus 68%. So about a 10% improvement in DFS at 2 years. And that was maintained across subgroups. And whilst incredibly early, there are signals of an improvement in overall survival. Does not reach statistical significance, very few events, longer term follow-up is needed. This does come at a cost, and we can see here the toxicities. Well, you say, well, these aren't horrible. They're not insignificant. 10% or so, less, just under 10% has stopped pembrolizumab for immune adverse events. We can see a lot of thyroid, but pneumonitis, I mean, 2% had adrenal insufficiency, 2% had diabetes. So this is not completely benign, but certainly it does have an impact. And when they did quality of life analysis presented at ESMO, there was no detriment in quality of life compared to placebo, with all the caveats that are the quality of life metrics that are designed for metastatic disease applicable to the adjuvant setting. So is this ready for clinic? Proponents say yes. There's an early separation curve, maintained at 2 years. That's a year after cessation of pembrolizumab. Toxicity is certainly less than sunitinib in the adjuvant space. And the adjuvant TKI and the M1 NED, the high risk population, was completely negative. Not so fast. This is only investigated DFS. There's no overall survival benefit as of yet. The rates of high dose steroids is not insignificant. It's near the improvement in disease-free survival at 2 years. And it's M1 NED really driving that signal. So I think we'll wait to see. I would imagine, given that sunitinib got approved, this will be approved by regulatory authorities in the near future. And this will become an option to discuss your patients with renal cell carcinoma. I can tell you, I'm not going to give this to every single patient. I feel much more comfortable giving this than sunitinib. And I think I would talk about it, but I think longer term follow-up is going to be important. And this slide just highlights that we've made great advances in clear cell. There's actually been some great advances in non-clear cell in the past year. And these are all the different trials. I think we saw data for cabozantinib and nivolumab in the study of non-clear cell disease with response rate close to 50% in papillary unclassified or translocation. While we haven't seen the same success with nivo-ipi, response rates less than 20% overall. So I think we're starting to see some of the advances in clear cell move their way into non-clear cell. We have multiple trials ongoing. We have an investigator-initiated trial in Boston looking at cabozantinib and nivolumab and ipilimumab in patients with variant histology. Move on to bladder cancer quickly. So there really was nothing great at ASCO, but I think I want to emphasize that maintenance avelumab is now a standard of care as long as you achieve a response to chemotherapy. So if you get platinum therapy and you have stable disease or better, maintenance avelumab is a standard of care. And that's given data presented at ASCO last year in the plenary, actually showing an improvement in survival of 7 months of 21.4 versus 14.3. So really, really quite remarkable data here. And this is established maintenance avelumab as a standard of care, independent of PD-L1 status, independent of anything. And I think now enfortumab vedotin is a new standard of care post-platinum, post-immune checkpoint blockade. So this drug has been approved in the US for over a year. This is an antibody drug conjugate against Nectin-4 with vedotin. And we saw data this year for the phase 3 trial of enfortumab vedotin versus dealer's choice of chemotherapy. And we see here is an improvement in overall survival of near 13 months versus 9 months with an objective response rate of 41%. Historically, taxanes in the space have response rate around 10 to 15%. So really, really quite impressive data and moves enfortumab vedotin into as a standard of care post-platinum, post-IO. And this is data that maybe you don't even need to give the platinum, which is a requirement in that one. So this was data we presented at ASCO, looking at those patients who had IO alone and got platinum. These were sick patients, median age of 75, 11% performance status of 2. These were very sick patients. What we saw here in this cohort analysis was objective response rate of over 50%, a CR rate of 20%, and no new toxicity signals. So clearly, enfortumab vedotin is a very active drug. And this data in the phase 3 led to the full approval of enfortumab vedotin for patients post-platinum or IO, or actually post just one line of therapy. So you do not have to get platinum and IO. You can go right to enfortumab after one line of therapy with this data. The other drug that's now approved, another antibody drug conjugate, sacituzumab govitecan. So for all those who are treating breast, far more familiar with it than I am in the past year. But this is an ADC against TROP2. And here we had data from the TROPHY-1 trial showing, this has activity, maybe not quite as impressive as enfortumab vedotin, but response rates close to 30%. And so this led to the FDA approval of this drug this year. Toxicities, incredibly different between these antibody drug conjugates. In enfortumab vedotin, we're looking at issues with rashes, neuropathy, and most notably hyperglycemia. So if you use enfortumab vedotin and you notice that glucose start going up, really you want to take a look at that and back off, because that can be signs of something worse to come, as opposed to SG, leukopenia, myelosuppression, and diarrhea. And the question is, do we even need to worry about the second line data? There's very exciting data updated at ASCO for EV plus Pembro in patients who are cisplatin eligible. Response rate over 70% with a median duration response of over 2 years. So this is really exciting data. This is the basis for a phase 3 trial that's ongoing right now. So in the end, I want to move on to prostate cancer, about 6 more minutes. There's been a lot of stuff that's happened in prostate cancer, starting with ASCO this year. So certainly we have a lot of new treatments, right? So we have a lot of novel hormonal therapies, but we haven't had a new drug. So this was one of the first new drugs. So this is an open label trial, VISION, of lutetium PSMA, which is basically radioactive lutetium ligand to PSMA targeted antibody, and also PSMA positive CRPC. So you can see here the eligibility criteria. These were heavily treated patients with androgen receptor inhibitor, as well as taxanes, and patients are randomized lutetium PSMA, which is given every 6 weeks for 4 cycles, up to 6, or protocol permitted standard of care, which basically means if you got abiraterone in the past, you get enzalutamide. If you get enzalutamide, you get abiraterone. Some would argue that's a expensive placebo, but that was the design of the trial. And I will note that while PSMA positivity was required to go on to the study, close to 90% of patients were PSMA positive by imaging. And so we see here, there's an improvement in PFS with a hazard ratio of 0.4, 8.7 versus 3.7 months, as well as overall survival, hazard ratio of 0.62, 15.3 versus 11.3 months. So this is certainly exciting data, and we have a new option for our patients. And given this a new agent, the concern is, are there toxicity signals? And really nothing of note. I will say PSMA is expressed on the salivary glands. So dry mouth is a toxicity that patients often have complained about, but no major myelosuppression toxicities. A lot of unanswered questions. Do we need PSMA PET? 87% were positive. Another data showed that independent of PSMA positivity, there's responses with this. When do we use it? Do we need to give it with standard of care? So I think a lot of things will come out. I assumed by the time I gave this talk, this would be FDA approved. We had the press release in early this year. We have yet to see an FDA approval. So when all the patients ask, when's it coming? I don't know. I think now the rumor is maybe early 2022. But this will certainly be something that patients are going to be asking about. And I think it really does offer a new option for our patients. But hopefully we can delay that. And so we're going to talk now about piece 1. So this is presented at ASCO and updated at ESMO. This is practice-changing data. So this took patients who had prostate cancer, and this is an extension of the STAMPEDE trial, which is a trial that keeps on giving. So this is a trial that looks at all these different endpoints where standard care, and they keep adding things. So they had, from November 2013 to 2018, they randomized patients in a 1-to-1-to-1 fashion to standard of care with abiraterone, standard care with radiotherapy, or abiraterone plus radiotherapy. And that standard of care evolved over time. So we know that in high volume disease, that Taxotere has a survival benefit. So initially it was ADT alone, 2015 and 2017, they said, hey, you can consider the Taxotere. And then by 2017 plus, docetaxel is mandatory. So with the follow-up here, looking at those patients over on this entire cohort, this is the patient characteristics. Again, mean follow-up 42 months. Standard care includes all patients in that arm. We can see that in general, these patients had high volume disease with its significant disease burden, reasonable PSA, and overall, that's the key demographics. And this is the key point. So if you look at those patients, we see docetaxel in that standard care, there was an improvement in radiographic progression-free survival. Here you can see, oh, it's not like, that's not months, by the way, that's 4.5 years versus 2 years. So this is a huge difference in radiographic progression-free survival. You can see the p-value is less than 0.001. Presented at ASCO, everyone's like, okay, that's great. We've seen other data before, but does it really mean anything? And no new toxicity signals, and that's important because when you look at signals for enzalutamide with docetaxel, there's been concern for toxicities. And here we have all these other trials looking at apalutamide, enzalutamide again. They all show different things. No one's really shown a clear survival benefit. So I had this whole big slide of like, we can think about this. Does it really make a difference? But then at ESMO, they presented that overall survival update. And we can see here in the entire group, it's 5.7 versus 4.7 years, hazard share 0.82. When you look at those patients who received docetaxel, we can see in intention to treat, it's the mean survival not yet been reached versus 4.4 years, hazard ratio of 0.75. And that's really remarkable in those high volume disease patients. And here's just putting that in context, starting where we started with ADT alone, adding docetaxel, you went from 40 months to maybe 48 months, ADT plus abiraterone, 50 to 55 months. And now with this, we see a median survival of 61 months plus. So really, really remarkable data. And in my opinion, ADT with docetaxel and abiraterone is a new standard of care in chemo-fit high volume disease. But hopefully we can stop people from getting there. So really quickly, STAMPEDE trial, it keeps on giving a lot of other arms. And they also look at localized disease. So those are M0 or high-risk disease. High-risk disease is not NCCN high-risk disease. This is no positive or T3/4, PSA greater than 40 or Gleason 8. That T3 or 4 could be by MRI. So it's relatively easy to get that disease. This is a trial design, 2,000 patients, randomized to standard care or standard care with additional novel hormonal therapy, that being abiraterone and enzalutamide or abiraterone alone. And we see here from the ICECAP database, we know that metastasis-free survival is a surrogate for overall survival. And so that was the primary endpoint of this analysis. And we can see an improvement in metastasis-free survival of 0.53. It's basically improving from 69% to 82% at 6 years. And that actually translates into an overall survival at this very early stage. This is not metastatic disease. This is high-risk localized disease. P-value, I mean, hazard ratio 0.6, that p-value is really low, 10 to the -7. I mean, a 6-year survival actually improved by 10%. So I would argue that this is now another new standard of care, the abiraterone for 2 years, in addition to radiation in high volume, in localized disease or no positive disease, is now a new standard of care. And with that, I would like to thank you.
Thank you, Dr. McGregor, for that great talk and staying on time. Very much appreciate that. It's my pleasure to introduce Dr. Arti Bhatia. Dr. Bhatia is an assistant professor of medical oncology at Yale New Haven Hospital. I'm proud to say that Dr. Bhatia became interested in head and neck cancer while doing graduate work at MD Anderson in the Department of Radiation Oncology, my specialty. So again, my pleasure to introduce Dr. Bhatia. I'm told Dr. Bhatia is joining us virtually today. Thank you.
Good afternoon, everyone, and thanks for inviting me here today. My name is Arti Bhatia. I am assistant professor in medical oncology at Yale Cancer Center, and I will be discussing head and neck cancer updates from the ASCO. And Jupiter-2 is the first international randomized controlled phase 3 trial of an anti-PD-1 antibody, toripalimab, in combination with gemcitabine and cisplatin for the first-line treatment of recurrent or metastatic nasopharyngeal carcinoma. This trial made it to the ASCO plenary session this year. Key eligibility criteria included treatment-naive patients with metastatic or recurrent nasopharyngeal disease, performance status ECOG 0 or 1, 18 to 75 years old, and with measurable disease. Patients were randomized to receive either toripalimab plus gemcis chemotherapy once every 3 weeks, or placebo and gemcis chemotherapy for up to 6 cycles, and then received either toripalimab or placebo as maintenance until disease progression, toxicity, or a total of 2 years. The primary endpoint of the study is progression-free survival, and secondary endpoints included overall survival and overall response rate, among others. Planned enrollment was 280 patients. Baseline characteristics were generally balanced between the 2 arms. A significant improvement in progression-free survival was detected in the toripalimab arm, 11.7 months versus 8 months, with benefits seen across all key subtypes and subgroups. Both PD-L1 positive and negative patients benefited from the combination arm. Although the median overall survival data is still immature, a 40% reduction in the risk of death was found in the toripalimab arm than in the placebo arm, with a p-value of 0.04. The objective response rates were 77% versus 66%. Next is another randomized placebo-controlled phase 3 study from Sun Yat-sen University, testing the anti-PD-1 drug pembrolizumab in combination with Gemcis in the first-line treatment of recurrent or metastatic disease. Treatment-naive patients with recurrent or metastatic nasopharynx cancer were enrolled. Other eligibility criteria included good performance status and at least one measurable lesion per RECIST. They were randomized to receive pembrolizumab plus Gemcis or placebo plus Gemcis for 4 to 6 cycles. And then patients were given pembrolizumab alone or placebo as maintenance until disease progression. The primary endpoint of this study was independent review committee assessed progression-free survival, while secondary endpoints included investigator assessed PFS, objective response rate, and overall survival, among others. 263 patients were randomized. The PFS by independent review committee was 10.8 months in the pembrolizumab arm and 6.9 months in the placebo arm, with a hazard ratio of 0.51 and significant p-value. Duration of response was also significantly longer in the experimental arm, 9.9 months versus 5.7 months. These results were consistent with those seen on Jupiter-2. Next, also from Sun Yat-sen University, is a phase 3 trial evaluating the role of Metronomic capecitabine in patients with locally advanced nasopharynx cancer. This trial enrolled patients with stage 3 to 4 disease, excluding node negative and T3N1 disease, as these patients are at a lower risk of disease recurrence. Enrolled patients received standard of care treatment with concurrent cisplatin radiation, with or without 2 or 3 cycles of cisplatin-based induction chemo per local practice. They were then stratified by the use of the induction chemo and randomized to either observation or Metronomic adjuvant Xeloda for 1 year. Primary endpoint was failure-free survival. 406 patients were randomized, with 80% having received induction chemo. The addition of Metronomic capecitabine resulted in better disease control and survival. 3-year failure-free survival was 85% versus 75%, while 3-year overall survival was 93% versus 88%, both supporting the consideration of adjuvant capecitabine in patients with high-risk locally advanced disease. Another randomized phase 3 trial from Sun Yat-sen also compared adjuvant capecitabine versus chemoradiation alone in patients with locally advanced nasopharynx cancer. Patients were eligible if they had T3N2, T4N2, or any N3 disease, pre-treatment plasma EBV DNA over 20,000, gross primary tumor volume over 30 cubic centimeter, SUV uptake over 10 in the primary tumor, or multiple neck node metastases with any which were larger than 4 centimeters. 180 patients were enrolled and randomized to receive either chemoradiation alone or followed by capecitabine for 6 months. The primary endpoint was 3-year progression-free survival, which was 87% versus 73%, favoring the experimental arm. And the 3-year overall survival was 92% versus 88%. For high-risk patients who were unable to receive induction chemo, chemoradiation plus adjuvant Xeloda represents an alternative treatment approach. Shifting focus to HPV-associated oropharyngeal cancers, TROG 1201 was a randomized trial of radiation with weekly cisplatin or cetuximab in low-risk HPV-associated oropharynx cancer. Patients were eligible if they had P16 positive, T1 to 2 N2 or N3 and 0 to 2 disease using the AJCC 7th edition staging. Patients with N2B disease or N2C disease were excluded if they had a smoking history greater than 10 pack years. All patients received 70 gray conventionally fractionated radiation and were randomized 1-to-1 to receive either weekly cisplatin 40 per meter square or cetuximab in standard doses. 189 patients were randomized. The median follow-up was 4 years, and the primary outcome was symptom severity assessed by the MDASI head and neck symptom severity scale, assessed up to 13 weeks post completion of radiation. There was no significant difference between cetuximab and cisplatin on the MDASI scale, but there was a significant difference in efficacy, as we know from previous trials. The cetuximab arm had inferior 3-year failure-free survival of 80% compared to 93% in the cisplatin arm, although there was no significant difference in overall survival. Investigators noted an increase in both distant and local regional failures. In conjunction with RTOG 1016 and the de-escalate trials, this trial again reinforces the fact that radiation and cisplatin remain the standard of care. Next was the Optima 2 trial from the University of Chicago, which evaluated nivolumab in combination with nab-paclitaxel and carboplatin, followed by risk and response adaptive de-intensification treatment for local regional HPV-positive disease. Patients with N2 or N3 nodal disease or T3 or T4 primaries were eligible. All patients received a 9-week course of induction chemoimmunotherapy, which included three-week cycles of nivo, nab-paclitaxel, and carboplatin, followed by imaging. Subsequently, they were assigned to one of 3 treatment arms based on their risk level and response to induction. Patients with T4, N2C, or N3 disease, greater than 20 back-year smoking history, or non-HPV-16 subtype were classified as having high-risk disease, while all others were categorized as low risk. The single modality de-escalation arm included low-risk patients that had a deep or over 50% response to induction. These patients received either robotic surgery or radiation alone to 50 gray. The intermediate de-escalation arm included patients who were high risk with a deep response or low risk with a suboptimal response, and they were treated with intermediate dose chemoradiation to 45 to 53 gray. All other patients were treated on the regular dose arm with standard dose chemoradiation to 70 to 75 gray. The primary endpoint was deep response rate, defined as the percentage of patients with greater than or equal to 50% tumor shrinkage following induction chemoimmunotherapy. The 2-year progression-free survival was 90%, and the 2-year overall survival was 93%. 70% of patients had a deep response to induction chemoimmunotherapy. This trial demonstrated excellent survival with high rates of deep clinical and pathologic response. Next, Dr. Ferris presented updated data from ECOG 3311, which is a phase 2 randomized trial of transoral surgical resection, followed by low dose or standard dose post-op therapy in resectable P16 positive locally advanced oropharyngeal cancer. The study population was P16 positive, AJCC 7th edition stage 3 and 4 oropharynx cancer, amenable to transoral resection. Post-op pathologic data was used to assign patients to adjuvant therapy. Patients with negative margins greater than 3 millimeters or up to 1 metastatic node and no extranodal extension were classified as low risk and assigned to arm A, which was observation. Patients with positive margins or greater than 1 millimeter of nodal extension or 5 or more metastatic nodes were classified as high risk and assigned to arm D, concurrent chemoradiation with 60 gray of radiation. And the study was powered by the randomization to arms B or C for patients with closed margins, less than 3 mm, up to 4 metastatic nodes, or up to 1 millimeter of extranodal extension, with or without perineural and lymphovascular invasion, and was stratified by smoking. The investigators also evaluated patient-reported outcomes for swallowing and quality of life. This was the study design. All patients underwent transoral resection. They were then stratified into arm A, low risk, arm D for high risk, or randomized to either 50 gray of standard fractionated radiation or 60 gray, which is the standard post-op dose, without chemotherapy for these intermediate risk factors. 2-year progression-free survival data was reported last year. This year, the investigators reported 3-year progression-free survival data, as well as functional and quality of life patient-reported outcomes. These are the 3-year PFS estimates. Arm A, 97%, arms B and C, 94 and 93%, and arm D, 90%. And these are the sites of recurrence. The study met its primary endpoint of upper bound of 95% confidence interval of PFS exceeding 85% across all arms. These were the MDADI and FACT-HN swallowing and quality of life scores. At 6 months, 56% of patients in arms B and C had stable or improved total scores versus 38% in arm D, with a borderline trend towards significance. There was also marginally significant improvement in FACT-HN quality of life total scores, with 63% in arm B versus 49% in arm C. Thus, TORS followed by de-escalated adjuvant radiation seems to be a promising de-escalation approach with merits evaluation in a phase 3 trial. Dr. Tricia Weiss-Draper from the University of Cincinnati presented results from a phase 2 window of opportunity trial using pembrolizumab in patients with locally advanced head and neck cancer. The study team hypothesized that adding pembro to standard of care radiation with and without cisplatin would improve disease-free survival in patients with resected disease. The primary endpoint was 1-year disease-free survival. Secondary endpoints included overall survival, changes in the immune microenvironment, and safety. Patients with radiographic evidence of 2 or more involved nodes or extranodal extension were classified as high risk and received 1 dose of pembro 1 to 3 weeks prior to surgery. Post-op, they were stratified into either high-risk group with positive margin or ENE, where current standard of care is cisplat radiation, or intermediate risk group where the current standard of care is radiation alone. On this trial, patients received standard of care plus pembro for 3 months. 92 patients were enrolled. At a median follow-up of 2 years, there was no significant difference in 1-year disease-free survival in the high-risk group compared to those on RTOG 9501. However, the intermediate risk group demonstrated 97% 1-year disease-free survival versus 69% historically, which met the primary endpoint for this group of greater than a 21% increase in 1-year DFS. The investigators also assessed pathologic response to neoadjuvant pembro. 40% of patients had some degree of pathologic response and had a significantly higher disease-free survival at 1 year of 100%, regardless of their risk status, compared to non-responders who had a 73% disease-free survival at 1 year. Patients with a high PD-L1 CPS greater than 20 were more likely to be responders versus those who had a PD-L1 CPS of 0. And finally, using the nanostring pan-cancer immunotherapy panel, IDO, interferon gamma, as well as PD-L1 and PD-L2 expression were all much higher in responders and was highly predictive of response to immunotherapy. And finally, Dr. Brose presented results from the randomized placebo-controlled COSMIC-311 data trial comparing cabozantinib to placebo in patients with previously treated iodine-refractory thyroid cancer, a population in which there is no current standard of care treatment beyond progression on VEGF targeting therapy. 187 patients were randomized in a 2:1 fashion to cabozantinib or placebo. Patients were stratified by age and prior lenvatinib use. Co-primary endpoints were response rate in the first 100 patients and progression-free survival, with progression being confirmed by a blinded independent review committee. The primary endpoint of PFS was met at the planned interim analysis, so trial enrollment was halted early. Median PFS in the cabozantinib arm was not reached, but while median PFS in the placebo arm was 1.9 months. The hazard ratio was 0.22 and was highly statistically significant. The PFS benefit was consistent across subgroups, including those above or below 65, those who received prior lenvatinib, and those who received 1 or 2 prior therapy. And these are the Kaplan-Meier overall survival curves. The study design allowed patients to cross over from placebo to cabozantinib upon disease progression. Despite that, we see an early separation of curves and a hazard ratio of 0.54. These are the results of the objective rate analysis in the intent to treat population, 15% in the cabo arm versus 0 on placebo. The disease control rate was 60% on cabo and 27% in placebo. These are the results of the objective rate analysis in the intent to treat population, 15% in the cabo arm versus 0 on placebo. The disease control rate was 60% on cabo and 27% in placebo. These data support cabozantinib as a potential new treatment option for previously treated iodine refractory differentiated thyroid cancer. To summarize the take-home points from this year's ASCO, PD-1 inhibition is the new standard in first-line recurrent or metastatic nasopharynx cancer. Adjuvant chemo following chemoradiation was again shown to improve outcomes in locally advanced nasopharynx cancer. Cisplatin is again proven to be superior to cetuximab as a radiosensitizer in the definitive treatment of HPV-associated oropharynx cancers. De-intensified radiation after TORS in HPV-associated oropharynx cancer yields fantastic 3-year progression-free survival results, and cabozantinib is the new standard of care after progression on VEGF targeting therapy for iodine refractory differentiated thyroid cancer. Thank you for your attention, and I'm happy to take questions.
I think we're going to be taking questions at the end, so there'll be one more talk. The next talk is something that we've all had to grapple with, particularly with the lack of any data until very recently. So collection of this data, I think, is extremely important for us. So Jeremy Warner, who's Associate Professor of Medicine and Biomedical Informatics at Vanderbilt University, will talk to us about COVID-19 and cancer.
Thanks very much. Can you hear me okay? So I thought this was going to be easy because I had 15 minutes to talk to you about 18 months of nonstop 24/7 media coverage and hundreds of thousands of articles, perhaps over 1 million. But now I only have about 5 minutes to stay on schedule. So we'll see what I can do. So these are my disclosures. I will probably take a little more than 5 minutes. Here we are 18 months in. Where are we at? We're in maybe probably past this 4th wave here in the United States. This part of the country maybe still kind of doing not so well, but this slide's already out of date. We just passed 700,000 deaths in this country, more deaths than in the 1918 flu pandemic, to put this into perspective. So, from the beginning, we were concerned that patients with cancer would be at particularly high risk from COVID-19, and here are some reasons why. You can read this review article, but basically there's concerns about more ease of entry of the virus, as well as disruptions in natural defenses, such as patients with lung metastases or primary lung cancer. Of course, cancer by itself is an immunosuppressive environment, and then most of our treatments are immunosuppressing. And but furthermore, there was this concern that also our immunotherapies or sort of immune provoking treatments would actually lead to these cytokine storms and also lead to poor outcomes. And then finally, there's this concern about thrombotic events, which we already know are pretty common in patients with cancer. So with that, first, I'm going to talk about some highlights from ASCO this year. I'm going to just talk about 3 abstracts. There are, of course, more than this, but we'll just kind of touch on these 3. So the first one was a presentation by a group called N3C, the National COVID Cohort Collaborative. Basically what this is a group of academic medical centers who put together a large amount of structured data into this basically huge data lake with over 2 million COVID positive patients, of whom many had cancer. And this was their first report looking at those patients. First of all, they found that patients who were hospitalized with cancer and COVID-19 did poorly, with survival probability 86% at 10 days and all the way down to 63% at 30 days. The rates of complications were somewhat low, especially things like ECMO were not used very commonly. In their analysis, they found that older age, male sex, having a Charleston comorbidity index of 2 or higher, and acute kidney injury were all independently associated with poor outcome. Here's a forest plot looking at various other factors that might be of interest to all of us. And much like our data, which I'll show you in a minute, they found that patients with liquid tumors or multiple tumors tended to do worse. And then when they really dig into the type of cancer therapy these patients were on, it seemed that cytotoxic therapy was the only one that was associated with an increased risk of poor outcomes. Importantly, I don't know, I think I have a pointer here. Oh, could you see no, you can't see that. Immunotherapy, second from the bottom, there's really no signal at all there for an association with adverse outcome, which is somewhat reassuring. So, really impressive thing about this study was that it's the largest to date electronic medical record-based cohort of patients with cancer with and without COVID-19. There are some real advantages to this type of cohort, such as the ability to get serial lab measurements or vital signs, those kind of data. However, there are really significant missingness in some dimensions. They don't have cancer status. They don't have ECOG performance status. These are things that are not easy to get. Even if they're written in a note, you can't necessarily pull it into a data set like this one. Also, when we looked at their treatment exposures, when I'm talking about treatment, I mean COVID treatment, it seemed that they started sort of really ramping this up later in the pandemic, so it's not as informative about what was happening in the early days. And one thing that really struck me was that there was really poor survival in both the COVID positive and negative patients, leading me to wonder a little bit about whether there's some sort of ascertainment bias. This study has been published in JCO, and that's the link. Here's another abstract. This is about telemedicine. Okay, so what is the future? How many of you, raise your hand if you've used telemedicine in the last year and a half? Almost everybody. Indeed, that's the case in California as well. So this study looked at how the pandemic changed trends. They had over 1 million messages and almost 350,000 visits across their large private community practice. So first of all, they saw that there was a little bit of a decline in overall monthly visits, but especially in office visits. So during this period, office visits declined by 80%, whereas video visits increased from 40 a month to nearly 5,000 a month. So a huge increase. They also had an increase in telephone visits and secure messaging, which I think we've all experienced sort of this increased burden of workload, sort of across the board. I think, one thing to emphasize from this study is that, telemedicine, teleoncology is not equally available to everybody. And we're seeing perhaps some new or different disparities emerge. And so kind of going through this table a little bit, what they found, and all of these are statistically significant, factors that would cause you to have more video visits were things like having commercial insurance, being of a more recent vintage. So the pre-boomers had sort of the lowest rate of telemedicine. Speaking English, certain races and ethnicities were more likely to do telemedicine. And there's even a difference based on sex as well. So these are interesting findings that we have to think about. Final abstract I'm going to touch on here is one that looked at end of life in patients with Medicaid. This was regional, so looking at Washington State. But somewhat representative. They found that people with Medicaid were younger, more likely to be Black, more likely to have lung cancer and to live in deprived neighborhoods. And what's interesting here is that before the pandemic, those patients were more likely than commercially insured patients to die in the hospital, and pretty big difference there. But during the pandemic, that really the statistics changed, and those patients were more likely to die at home without hospice services. And so, whereas for commercial patients, these things didn't really seem to change much at all. So this is, pretty interesting in terms of healthcare delivery. And, one takeaway from this is this similar? I'm not aware of other studies from other regions, but is this, something we would see kind of across the United States? And I think importantly, which they didn't really touch on, is that do these changes actually change life expectancy for Medicaid patients? But certainly there's a real change in the practice there. Yeah, I'm going to pivot now and talk about our consortium a little bit. And let's see. Yeah. Okay. So, first of all, our consortium is also 18 months old. It was founded in mid-March by tweet by this then resident, now fellow at the Mayo Clinic, Dr. Akash Desai. We started with 5 sites. We got a logo, we got a Twitter account. We kind of built it up pretty quickly. And this is even out of date now. We're up to more like 130 institutions. But I want to give Dr. Wise Draper her second shout out of the hour for being really instrumental in this consortium. She's the lead at the University of Cincinnati, which is one of our best participating sites. So we're really grateful for that. We have over 500 investigators that are involved in one way or another. This is our steering committee and our operations, but maybe this is the key slide. We really have started quickly and have continued to accrue patients at quite a fast pace. We just passed our 12,000th case in our registry. And these are some of our sort of earlier, but I think still relevant findings from 2 papers that were published last year and earlier this year. And so basically what we found is that and this is mostly United States, a little bit of Canada and Mexico, but essentially the death rate at 30 days is over 10% in patients with cancer and COVID-19. There's also substantial rates of other complications such as mechanical ventilation, ICU admission, and more than half of this cohort had required hospitalization. When we look at, we split this into 2. So these are general factors that might affect prognosis in our analyses. And the first one is age. And so actually there's an interesting nonlinear relationship where age below 40 is essentially very little to no risk. Obviously, most patients with cancer are older than 40, but we kind of see the risk basically go up after that, and it's kind of linear with age, much like the general population. We see the patients, male sex is again as a known risk factor, non-Hispanic Black versus non-Hispanic White, and also Hispanic. So we see these racial and ethnic disparities. We do not see smoking as a risk factor. It's kind of on the edge there, and obesity has been interesting. And I think that's because in our population, as you know, being cachectic is probably worse than being overweight. And I think we see that in our data set as well. So obesity doesn't really show as a signal like it does in the more general population. Really interestingly, and I'm sure you may have hopefully observed this in your own practices, the risk of doing badly has gone down over time. That first wave seems to have been the worst for patients with cancer. However, in our most recent analyses, so kind of looking up to as much as yesterday, I mean, more recently, it seems like, unfortunately, that patients with cancer are doing badly again. So what we see here in the sort of May to mid to late 2020 range might actually reflect more about healthcare system, the lack of overload. So it's hard to say, but unfortunately, we're kind of seeing that mortality rate creep up again. These are cancer-specific factors that we've seen. Now, remember I talked about N3C, how they didn't have ECOG or cancer status. Well, we do have that in our data, and we see that those are really strong drivers, which should not be that surprising, I suppose, but this just kind of proves the point. ECOG even of 1 versus 0 had almost 1.5 times rate of poor outcomes, including mortality, and ECOG 2 and above just really highly associated with bad outcome. Again, we saw, like they did, hematologic malignancies seem to do worse. And then patients with active progressing disease versus those in remission seem to do worse. And there's probably a lot of reasons for that above and beyond the cancer, perhaps. Like N3C, we saw that cytotoxic chemotherapy is associated with problematic outcomes. And like N3C, we did not see any signal with immunotherapy. These are some lab parameters we also looked at. I'll kind of skip past this in the interest of time. Just want to talk a little bit about treatment exposures. So this is a study that we published back in last fall. And one thing I want to emphasize is that, it's interesting. I think we'll look back at this later and think about, what we did as a community, giving patients these, basically unproven medications. Wouldn't have been, I think, as much of an issue if it had been done on trial, but you can see those numbers on the right. So few of these patients got drugs like hydroxychloroquine or azithromycin on trial. It was kind of shocking. And that also includes drugs like steroids, which do now have a track record. In this study, basically none of the patients who got steroids got them on trial. And then you contrast that with drugs like remdesivir, which wasn't really available in other way, and more than 2/3 of the patient got that on trial. Yeah, that just emphasizes that. Now, here we have this. Hopefully no one here has, actually, I think there was something in the news in this region about a hospital trying to be forced by a legal system to give ivermectin, which they did not in the end. And this one we're not looking at right now, but hopefully it won't take off like some of the others did. So this was our analysis. This is a bit complicated. I won't really dwell on the details except to say we found no benefit for hydroxychloroquine. We likely found evidence of harm with that drug, comparing to positive and negative controls, basically any which way you look at it, increased mortality with that drug. Potentially a signal for improvement with remdesivir, although with a major caveat that most of the comparison patients got hydroxychloroquine in that particular comparison. This is one treatment, or the only treatment that we found to have a potential beneficial effect, and that's convalescent plasma. And this article is out in JAMA Oncology recently, but basically it seems that there's a survival benefit in patients with hematologic malignancy, which makes a lot of sense. They don't have much antibody of their own, and this is seeking to restore it. We have not published on this, by the way, but we don't see the same signal in solid tumors, and maybe even a signal of harm. We're looking into that further right now as our numbers have increased. So I'll kind of, wrap that up here. There's a lot of questions. I won't go through these. I'll just let you kind of look at them for a minute. I feel like, we've scratched the surface. There's a lot to learn about COVID-19 in patients with cancer, including, I think, most importantly, what's going to happen to these patients over time. The patients who got infected, are they going to have a different course over the upcoming years? Are they going to if they were in remission, are they going to progress more quickly or not? These are, I think, important questions for our community, which we're going to have to observe these cohorts for years to understand. I think, the question about imaging changes, there's enough anecdotes out there, especially even with vaccination, about patients with breast cancer having axillary adenopathy from the vaccine, and that makes them worried about recurrence, or it confuses the question about progression. There's a lot of questions about breakthrough infections and how severe those will be in these patients with cancer. And so that's it. I just want to acknowledge the patients, their families who have contributed to our registry and all the institutions. Thank you.
If you want to stay up here for questions, we have a couple minutes for questions. Yeah, Dr. Ahmad, the microphone is going to be coming your way.
Jeremy, thank you very much. Great talk. Syed Ahmad, University of Cincinnati. First of all, I want to thank you for leading this effort. We've learned a lot from the consortium that you and others have established. Two questions. One is, do you have any data about outcomes in cancer patients who've been vaccinated? Everyone quotes a 10 to 15% death rate if you have cancer or being actively treated and acquire COVID. So you probably have mature data now where you can look at cohorts that have been vaccinated, have not been vaccinated. Can you also comment on the risk of patients on immunotherapy and whether or not they have any ill effects from being on that particular type of treatment? Thank you.
Sure thing. So the question about vaccination is obviously really key to us as well. And we have made a targeted search for patients with breakthrough infections. I mean, the good news is that they're not that easy to find, even across our many active sites that are reporting cases. We could only find a few cases at each institution. So we have a cohort that we're actively analyzing. I mean, you're right. It seems that, vaccination is not a cure-all at all for patients with cancer, nor everyone. But from what we've seen, that there are still severe outcomes, unfortunately. So other mitigation measures are really going to be important for these patients for some period of time still. So for the other question, I think from what I presented, both from us and from others, there's no signal that immunotherapy is associated with adverse outcomes. We did, and I think we presented this at ESMO, see, suggesting that chemoimmunotherapy, so the combination, the numbers were very small in the number of patients who were actively being treated with chemoimmunotherapy at the time they got COVID-19, but those patients didn't appear to do so well. It might be that the cytotoxic chemo is driving that. It might be that other factors are driving that, such as them often having lung cancer and other factors that might, being older and so forth. So I think we are planning to go back. Our data set is now more than twice what it was. We're planning to go back and look at that kind of exposure a little bit more carefully.
What do you tell your cancer patient that refused taking the vaccine?
So, I mean, usually they've already had COVID at this point. However, they should probably still get the vaccine. Having the infection doesn't necessarily protect you from another infection. But I think the issue is, especially, so I treat hematologic malignancy, and some of those patients will not seroconvert. They may not benefit from the vaccine like other people, and so. I mean, if they choose to refuse, that's one thing, but if their family chooses to refuse, I think that's a bigger issue. And I think just like we have always done with flu vaccine and others and transplant patients and so forth, that we have to really emphasize that they are cocooned with, with family members, caregivers that are definitely vaccinated. Usually the people who refuse vaccine are also the people who don't wear masks either, but, we try to do the best we can to convince them otherwise.
So I had two questions for Dr. McGregor. One's a bladder question and one's a prostate question. So for bladder, we've had all these new therapies available to us now, the antibody toxin conjugates and immunotherapy, and still for early bladder cancer, the paradigm is cystectomy, which is really life-changing. So with these new potential drugs, what kind of trials are going on right now in terms of bladder sparing approaches using these new drugs? That's the bladder question. And the prostate question on the PEACE-1 trial, there was great data using that combination with the 4.5-year survival. But what about sequential therapy if someone were to do docetaxel followed by abiraterone at a later date? Is that clearly inferior, or is that not known yet?
So I'll start with the bladder question. I mean, I think that's the major question. Can we spare the bladder? I think they present some data at ASCO for this very question. And the fact of the matter is we're really bad at knowing if our bladder therapy works in that neoadjuvant space. So chemotherapy alone, we know if we do a cystoscopy, we're not going to be convinced that a CR is truly a CR. There are multiple options. Like chemoradiation is certainly an option for patients with bladder carcinoma who want to spare the bladder. They have a small tumor, no associated CIS, are cisplatin eligible. And so there's a trial ongoing right now with chemorads with or without atezolizumab in that space. I agree. I think these ADCs are very exciting. And so I would love to see, data from like the 103 cohort looking at EV plus pembro in that neoadjuvant space. So right now, if you're cis ineligible, we just go right to cystectomy. But if EV pembro has a 70% response rate in the metastatic setting, is that going to lead to some past CR rates in that neoadjuvant space? And we're going to prevent patients from getting to metastatic disease, because I think EV is a great drug, but when you give it forever, it's not a fun drug. The neuropathy builds up over time. So I think this is certainly an unmet need. I think the idea of trying to avoid a cystectomy is challenging because we don't have great biomarkers. I think some data like ctDNA, there's great data for Natera ctDNA that, using that, you may be able to predict if patients are going to relapse or not. And maybe we can use that to try to spare a cystectomy. I think these are unanswered questions. Regarding the prostate question, I think that's a little bit of an unknown answer. If you try to do like subgroup analysis of prior trials and do all those things, it doesn't seem to be the same signal for like, prior docetaxel, then get enzalutamide. There may be some synergy there. Now, this is not to be started at the exact same time. You can start abiraterone and then start docetaxel 3 months later. But I do think that, in the situation of a patient who's chemo fit, so that's the important thing. This was not looking at abiraterone and ADT versus abiraterone docetaxel ADT. Everyone got docetaxel. So you had to say, okay, is this a chemo fit patient? If it's a chemo fit patient, I think the data is pretty compelling that we should be adding abiraterone to docetaxel in that setting. Now, if you have a low volume patient, where you're going to offer radiation, maybe radiation replace the docetaxel as your non-hormonal manipulation. And the data, I didn't show that, but the data for low volume, it's like immature. It's not clearly that there's that big benefit. And CHART would suggest that there's no benefit to docetaxel in low volume patients. So again, I think the first question is the patient chemo fit? And if the patient is chemo fit, I think you really should be adding abiraterone to docetaxel based on that data. There's a lot of people doing sequential approach. You docetaxel, if the PSA doesn't go down, add abiraterone. I think these are all reasonable ideas, but I think the data is pretty compelling. No increase in toxicity, and add it. Now, if you do well and maybe at 2 years, your PSA is less than 0.02, you can certainly think about a break. I think that's there's an alliance trial that's going to ask this very question. Can we stop abiraterone metastatic disease when the PSA goes down really low to minimize toxicities? But I think the data is pretty compelling, and maybe early sequential therapy would be good, but I don't think true sequential therapy is going to be the answer in that situation.
I have a question for head and neck cancer.
Yep.
For
Yeah.
a patient with HPV positive bulky disease with non-smoker, is it time now to consider lower dose of radiation or skipping up the cisplatin or both? And if we can do this, what kind of dose of radiation is be ideal? Do we have to wait more studies or do it now?
Yeah, so I think any de-escalation is on trials so far, and especially if you're talking about bulky disease, I mean, either T4 and 3, these historically tend to do poorly even with standard treatment, like the disease-free survival 3 years out is about 50% for this subgroup. So this is not the subgroup that needs to be included in the de-escalation question. It's really more the favorable group. So T1, T2s, N2s at best, but really the bulky disease is not something that we're including in the de-escalation question. But any de-escalation for any subgroup right now is on a clinical trial. There's just been so many different strategies exploring induction followed by de-escalating radiation, or surgery followed by de-escalating radiation, or just definitive treatment with dose-reduced radiation, or other drugs like exploring immunotherapy, exploring lower doses of cisplatin, fewer cycles of cisplatin. It's just been such a varied question that I just don't think we're ready to implement any one strategy yet.
Okay, thank you.
Outside of a clinical trial.
Thank you very much. Thanks to all the speakers.